I am now handing over to Ameza Reitmeyer, the VP of Commercial Marketing, CRHF Diagnostics at Medtronic, to introduce our Executive Spotlight session of Dr. Cara James, moderated by Dr. Archelle Georgiou. Thanks for joining us, Ameza.
Yes, thank you so much for having me, Pinar, and what an amazing way to start this last day of the Convene Conference. So my name is Ameza Reitmeyer, and I am, as Pinar said, I'm the Vice President of Commercial Marketing for the Cardiovascular Diagnostics and Services business at Medtronic. I'm also a very proud alum of the Carlson School. I was part of the first graduating cohort of the Medical Industry Leadership Institute and a proud supporter. And I represent Medtronic on the National Industry Council, so really delighted to have the opportunity to support Convene and also to introduce this amazing executive conversation that we have. So let me start with Dr. Cara James. She is the President and CEO at Grantmakers in Health. Prior to joining GIH, she served as the Director of the Office of Minority Health at the Centers for Medicare and Medicaid Services, where she provided leadership, vision, and direction to advance the U.S. Department of Health and Human Services and CMS goals related to reducing disparities and advancing health equity for vulnerable populations, including racial and ethnic populations, persons with disabilities, sexual and gender minorities, and persons living in rural communities. Under her guidance, CMS developed its first CMS equity plan to improve quality in Medicare, its first rural health strategy, and created an ongoing initiative to help individuals understand their coverage and connect to care. She increased the collection and reporting of demographic data and developed numerous resources to help stakeholders in their efforts to reduce disparities. Before joining CMS, Dr. James served as the Director of Disparities Policy Project and Director of the Barbara Jordan Health Policy Scholars Program at the Henry J. Kaiser Family Foundation, where she was responsible for addressing a broad array of health and access to care issues for people of color and other underserved populations, including the potential impact of the Affordable Care Act, analysis of state-level disparities in health and access to care, and disparities in access to care among individuals living in health professional shortage areas. Prior to joining the foundation, she worked at Harvard University and the Picker Institute. Dr. James is a past member of the National Academy of Sciences, Engineering, and Medicine's Health and Medicine Roundtable on the promotion of health equity and has served on several NASCM committees. She's also a published author of a number of peer-reviewed articles. Dr. James holds her doctorate in health policy and her bachelor's degree in psychology from Harvard University. And when I shared her profile with colleagues of mine at Medtronic, my favorite response or reaction was, she is a boss. So very excited to have you here, Dr. James. And this conversation will be moderated by a dear friend and amazing supporter of the Carlson School, Dr. Archelle Georgiou. Dr. Georgiou has an extensive healthcare background as a practicing physician, business executive, author, and speaker. Previously, she was Chief Medical Officer at United Health Group. And Dr. Georgiou now teaches at the University of Minnesota's Carlson School of Management. She also sits on the boards of CaringBridge and the Children's Hospital of Minnesota and lectures extensively on health topics, hosting weekly medical segments on the ABC affiliate KSTP TV in Minneapolis, St. Paul. She's an amazing author of Healthcare Choices, 5 Steps to Getting the Medical Care You Want and Need. She's also briefed the White House, World Bank, and the Surgeon Generals of America's Armed Forces on health reform, and has been an expedition doctor and medical correspondent for the AARP and National Geographic's Blue Zones International Expedition to Ikaria, Greece. With appearances on Fox Business Network, CNN, Good Morning America, and other network programs, Dr. Georgiou's greatest passion is using the media to educate American consumers about health and healthcare choices. And I'll also say you've been an incredibly valuable source of trusted, candid, concrete information for me and my family as we've navigated the pandemic. So Dr. Georgiou and Dr. James, it's my great pleasure to welcome you to Convene and to turn the conversation over to you.
Ameza, thank you so very much. I'll make sure that we transition. Thank you so much, Ameza, for the introduction. And I would wholeheartedly have to agree with you that, Cara, you are a boss. So I am so thrilled that Ameza did justice to your introduction because you have achieved so much. So I just want to make sure that we can hear each other since we're on Zoom, and wonderful.
Yes, I can hear you. Can you hear me?
Absolutely. Wonderful.
Great.
Well, thank you for joining us today. And I know I sent you a text message just earlier this morning saying how very honored I am to have the opportunity to do this. So I just want to say that publicly, because having your wisdom, your experience as part of this forum is really important to us, and will benefit all of us. So thank you so much.
Thank you for having me.
Absolutely. So there are so many questions that I want to ask, and I really thought carefully about the order in which we would do that. I'm going to start with maybe what most people feel a little more familiar with, which is your role as the director of the Office of Minority Health in CMS, and then we'll transition to other parts of your career as well. So at a high level, it sounds like we might understand what that is, but it was a brand new office when you were there. It was launched as a part of the Affordable Care Act. I'm wondering if you could give us an overview of that office and of your role in that office.
Sure. So, well, again, thank you so much for having me and allowing me to tell my story a little bit and share some wisdom. But the Office of Minority Health at CMS was, as you mentioned, one of the offices created with the Affordable Care Act. And while a number of the agencies already had them, such as CDC, AHRQ, HRSA, as well as the National Institute of Health, and there was an office at the department, CMS, SAMHSA, and FDA did not have these offices. So the Affordable Care Act said that we should have an office. It did not necessarily specify what we got to do, which was really exciting for me as a leader to be able to think about what is the vision of what I thought that office should be and to put that in place. So I came in on March of 2012 and literally had to create the structure of the office. So there was one box on the org chart and thinking about what is that we thought the office should do. So very importantly to me was to make sure we had data. So we set up a data and policy analytics group to be able to look at what disparities we had. Another part that I made sure that we had is a group that focused on program alignment and partner engagement. And program alignment really is thinking about, CMS is a $1 trillion agency. It runs Medicare, it runs Medicaid, it runs the marketplace. It also does hospital quality, dialysis, nursing homes, as we all have heard in the news lately. And so really thinking about every single one of those boxes on our org chart as a potential partner, an opportunity to infuse a focus on health equity. So that was really what that group was thinking about, as well as how we worked with external stakeholders and communicating with our beneficiaries about changes to help empower them in their health decisions. So that's kind of where we started, and looking at the data and how we could build that in. So we went from there.
So I want to dive into the data in a moment, but when you step back, and I can only imagine what it felt like to walk into that office with one box on the org chart and maybe one box on your desk because it was new. How did you even approach setting your priorities? How did you do that?
Yes, that was hard, I will say, because when I look at, the opportunities, for me, the question is always not what to do, it's where to start. And so there's so much that could be done because it was a new office. And so looking at that lens, there were pieces of the agency that thought about health disparities a little bit more than others, but really all those opportunities. So one of the priorities, one of the easy priorities really to lift up was, at that point in time, a lot of attention and effort was being focused on starting the marketplace. And of course, initially in 2012, we were waiting to hear whether or not the Supreme Court was going to uphold the Affordable Care Act. But that was one where I remember talking to our small team, because it was 6 people that we had, about what role we wanted to play. And we very easily could have said, we don't have a staff, we don't have a budget, we can't really engage in this. But I felt like saying that would have created the office to be irrelevant, because at a time when the agency was really focused on that, at a time when 6 out of 10 of the uninsured were people of color, to say that we couldn't because we were so new was just inexcusable in my mind. So really thinking about what is the role that we could play in helping to move forward with this huge effort that was underway. And so that's what led to the initiative called From Coverage to Care, where we said, we really, the Affordable Care Act was good about helping people get connected to care through navigators and other programs that were going to be set up through our colleagues. But it was really silent on what happens once people get coverage in terms of how do you help them understand their coverage and use it to get the care that they need. And again, thinking about who the uninsured were, the notion that you're going to give people a card who've been insured for 2 years or more, who haven't had a usual source of care, and they're going to figure out this very complicated healthcare system, I think left a lot to be desired. So that's where we felt like we could make a commitment and engage and really have a valuable role to play. And so we did. That was one that we started with, but also another priority on the piece of just understanding what the disparities were that we had across our different populations. So using some of our data to put out some products and pieces.
So what I'm hearing from you, and I'm just highlighting this for our audience, is that you harnessed your interventions on the train that was already out of the station, the Affordable Care Act, and making that more successful. And as I heard you say that, it's just such an important lesson for all of us that we need to look at how we can not just do things independently, but integrate with other initiatives, and that creates success, greater success for all of us. So I know that in our preparatory call and just a few moments ago, you mentioned that you focused on data. And I know that that was such a big accomplishment and you're really proud of it because it was so important. When you started, I want to dive deep into that data. And how much data was there? Where did you start? How did you start?
Yeah, so there's a lot of data at CMS, needless to say. But there's also, when we think about minority health, some places where we don't have great data. So completeness of the data and just where we have it. So we have good data in Medicare. There's been significant efforts over the past couple of years to improve the data in Medicaid, but we were unable to provide a national picture of what was happening in Medicaid because it's a state-run, sort of state program. So you looked at each state, and I remember being really just kind of disheartened when I sat down with some of our colleagues on our Medicaid side to look at the data to say, well, couldn't we just do something, one number that could tell the story? And we literally looked at each state's data on race and ethnicity, and it was not possible. So it just, okay. Then we looked on the Medicaid side and understanding where CMS gets its race and ethnicity data on Medicare beneficiaries. People may be surprised to know it actually comes from the Social Security Administration when an individual enrolls in Medicaid. And Social Security gets that from the birth certificate when an individual was born 65 years ago. So it's not exactly the most current data. And we were looking at how we could understand what was going on in that space and improve that data and how we could use that in other places. So working in making sure with the marketplace, for example, that it had race and ethnicity on the application so that we could understand who got enrolled in coverage through that were some of the things. And looking as well in our other programs like ESRD and where we have, we know disparities exist in terms of individuals who get dialysis and are getting a transplant, what we could understand there. So we just kind of went sort of system by system to see where there were opportunities and what we could say. And we were able to say much more in the Medicare space than we were in Medicaid, but sort of working to improve that where we could.
And I'm sure that you faced technical barriers, but I'm actually wondering what types of trust barriers you faced. And so, there could be, while you were going to use that data for good, there is a lot of skepticism about how data is used. And I'm wondering if you faced that, and if so, how you overcame it.
Yeah, I think, it's interesting. I'm remembering, unfortunately, two conversations that I had, one early at my time in CMS and one on the other side as I was leaving, where the question was asked, why do we need to collect data on race and ethnicity? And I think that today, we would all say that there's clear wisdom in why we need to collect that, but that, was a challenge that we were having to face, where it was not the environment that we're in now, where I think everybody was really supportive of the work that we were doing. So we had to work to build trust, to show that we were coming together with opportunities to both help and seeking assistance. So we approached our colleagues with not just, sort of a handout asking if they could help us with something, but coming to them saying, here's how we can help you do the work that you're doing. I think on the data side as well, the quality controls that we have, there were some things we didn't publish because we didn't trust the quality of the data that we had. And we worked as well to think about how we could improve what we had so that there was more trust in the information that was being put forward. But I think those were a couple of the things that we sort of thought about in the trust space.
And there was another comment that you made when we talked earlier, and you said there's a lot of data, we just don't use it. Would that be one of the issues, is that you don't use it because you don't trust it? Or what, in addition to that, if that was one of the reasons, what are the other reasons why we don't use data?
I think sometimes we don't use it because that's not the focus. And I think about, what we're focusing on. If we're talking about national numbers, for example, then we're not looking necessarily at what's happening at a state or a local level. We're putting out those broader numbers. And I think for some of the programs that are as large as they are, the focus just is on the broader aspect of it and not necessarily some of those segmentations of what's happening in different population groups. I know in talking to health plans and health systems, it's the same thing that when we would go out and talk about disparities, I would ask the question, how many of you collect this information? And anybody who's been in a hospital has been asked these demographic questions about, race and ethnicity or language or those sorts of things. And then I'd ask the question, and how many of you are looking at quality data stratified by these population groups? And no hands would go up. And it's kind of like it's not necessarily a focus of the work that we're doing. So I think that there's a number of reasons we don't, but there is also, when we think about some of the data that we do need, we may not be as good in having that. And, Jennifer was talking about in her speech just before this, data on social determinants, food, and those sorts of things. And there, I would say we're doing much better, but we still have some gaps in understanding what's happening to provide that full holistic view of individuals and their needs.
So that's actually a great segue, those gaps. And I know that we have improved, but not enough. So to go to one of the areas where we're focused a lot on equity right now is COVID vaccination rates. And the CDC, I'll just read this from my notes, but the CDC is reporting race and ethnicity data of the people receiving COVID vaccinations, finally, not reporting it at a state level. But we only have that information for 55% of the population. And as you might expect, even in that data, the people receiving vaccinations is disproportionate to the representation of those groups in the population. So I think that you would agree that we're not there yet, but what is the role of our public health systems, which is very patchwork, the CDC, in coming together with the Office of Minority Health and other government agencies to address this issue? And maybe focus, I know that was a big question, but I'm really struggling with the CDC and our public health system. And I'm wondering if you could address that through your lens, because you've had such a front row seat to that.
Yeah, I think there are a couple of reasons that we have missing data. On the one side, we have individuals who may be concerned about giving the information and how it could be used. So what we do there and what we've seen successful is to provide what we call help texts or explainers of how the information is going to be used. And once we give that information, we find that people are much more willing to provide that information. The other side, we see that people just don't ask the question. So that's part of the reason we also have that missing. So helping and training people for why it's important not to skip that question, but to make sure we are asking it and filling that information in. There are things that we saw last year in terms of what was happening initially with the pandemic, that we weren't getting data on who was getting testing. and that there was a requirement that was put forward that states and others report data by race and ethnicity, but that started in sort of August. So that's one thing that can be there, is that tool of requiring the data to be captured. And that has happened in the cases initially with making sure that the electronic health records had a field to capture that information. The other thing is thinking about our data systems. So when we looked at, again, going back to the Medicaid data, each state does things differently. There are infrastructure needs that states have in order to be able to update their systems in public health and in Medicaid to be able to report that information in. And it does take resources to do data collection in some respects. So making sure that those resources are there. So I think one last thing I would say is to make sure that we have data standards so that we have apples to apples coming through, and that we're not getting a fruit salad of data where you can't really combine that to give a complete picture. So I think the role of kind of the government and others to help provide some of those data standards. And also there are incentives that can be used at the state and public health level to give them the infrastructure needed to update the systems to be able to capture it, and training of the people who are actually inputting that information and collecting it to make sure they understand why it's important that we have it. And finally, for the people to make sure they understand why we're asking and how it will be used to ensure that good quality care is provided to everyone.
And I heard a key term, which is data standards. So as the government and other organizations are collecting data, we have to have that broader lens of how can we all use the data. So there need to be some data standards. I'm going to use this moment to transition on what you're doing now, because you had 8 amazing years in DC, but you're doing something new now. And I want to talk about Grantmakers in Health. And it's Ameza introduced it. It's a nonprofit educational organization focusing on grant-making communities, focusing on improving grant-making communities' knowledge, skills, and effectiveness. But what does that exactly mean? And how do you work with other organizations?
No, so it's great. So Grantmakers in Health, we are approaching our 40th anniversary, and it's been a great time. I've been here not that long, so I still am learning so much about the organization, but we work primarily with foundations and corporate giving programs to help them as they say, learn, connect, and grow. And we help to educate them on a variety of health topics and health needs, but also to learn best practices and share lessons learned from each other. We also work with other organizations. So collectively, the foundations obviously had a big role in helping to support communities in the outreach and enrollment with regards to the Affordable Care Act last year, and continuing into this year in supporting communities around the pandemic, making sure they had access to PPE, providing food and other needs in the immediate needs for the community, and working to do rapid response grants. So those are some of the ways that we have looked at that. We started last year in increased attention to health equity and diversity, equity, and inclusion, a leadership group that engaged to talk about how foundations were approaching health equity and responding to that. And we did a survey of the field to understand what was going on there. We also had a number of foundations who engaged in civic engagement. There was obviously a lot of activity last year, not just with the census, but also with the election and voting. And it's one where people may not necessarily think about health foundations engaging in that space, but there are a number who do. And that was a topic of focus for our fall forum last year, where we brought people together to share lessons learned and move forward. So those are just some of the ways. We also write sort of issue briefs on different topics like behavioral health or other surveys, but help both funders and non-funders who are interested in health connect to each other to work towards better health through better philanthropy.
And in one of the blogs that you wrote earlier this year, it was just so targeted. You were referencing the American Rescue Plan Act of 2021, and you said that philanthropy can help to ensure that we don't squander this moment. And I loved how blunt you were in your blog. And I'm wondering how philanthropy can help. And what did you mean by squandering this moment?
Yeah. So, well, first of all, good real time, because that just came out yesterday. So, well, good research there. Yeah, no, I think this is a really important time, and we see, and I think even in the case of health equity, but I'll speak specifically to what I was referring to there. There is a lot of money between the American Rescue Plan Act, the end of year's stimulus package, the CARES Act, and potentially more coming through the infrastructure bill if that gets approved by Congress. A lot of money coming into communities, and this money can be used to do so many of the things that we're talking about that are needed to rebuild our economy and also to strengthen our communities so they're better fortified for future whatever challenges that they may face. But we also know that states are struggling, that we've seen, with the year, the toll it has taken, the burnout, and the loss of staff across many places, that communities, particularly smaller and under-resourced communities, may not have the capacity to be able to do the planning to figure out what the needs are, let alone have the capacity to put together a grant for submission for resources that are not automatically flowing. So there is a concern, I will say, that I have, that if we don't provide the opportunity and the resources to help plan for how best to spend this money, we could have a number of bridges to nowhere that are spent once we look back at where the money has gone. And that's what I mean in terms of let's not squander this moment. We are in a time where we haven't seen this many resources going to community in a very long time, and they really could be used to help. But without good planning and management and support, we may not realize the goals of what we all were trying to achieve in Congress in passing this money.
You have seen and evaluate so many solutions. I'm wondering if any stand out as particularly innovative, effective, and sustainable. I don't mean to put a Sophie's choice in front of you, but I'm wondering if you have seen anything that just rises to the top of a model that you think will work.
And a model that works for what exactly?
Addressing health equity, any element of health equity issues. There, it's such a broad field. It's hard to narrow, but
yeah, I think so. One thing I would say, and I go back to one of the things that we started when I was at CMS, was our Health Equity Awards. And those were started for exactly this purpose, to showcase some of the things that people have been doing that are successful, to counter that narrative of these are such pervasive problems that we just can't do anything about them and they're intractable, and to provide some support for those who are doing the work, because prior to March of last year, I would say that the field of folks who were focusing on health equity was not nearly as robust as it is now. And it's great that we have so many more that are here, but often the folks who did the work of health equity were small and sometimes under-resourced. So we've seen examples right in Minnesota. We actually gave Health Partners an award for their efforts to reduce disparities, focusing in the Latino community around some of the language access needs and behavioral health combinations. So they were able to reduce length of stay for individuals through language learning and outreach support there. So that's one example. There have been others. Some of the Kaiser Permanente in California had a long-term 10-year commitment to reduce blood pressure disparities and hypertension, and they were able to do that and reduce Black-white disparities. So there, I think, a lot of different things that people have tried. One other example I'll just say, I think about Centene, who actually put together a grant to update and improve physical accessibility of provider groups. So giving money to provide ramps, to widen doors, those sorts of things to make the practices actually more accessible. So that obviously helped to reduce disparities for people with disabilities. So there are a number of examples. I think where we still have some struggles and sort of we've seen some examples in terms of how we need to reduce the disparities in maternal health that we still struggle with. But there's some good shining, try to lift those up so that others can learn from them.
Wonderful. We did get a question from our audience, and I want to make sure I fit that in before I go to my final questions. And this is from Ann Schulte, and she says, there's a lot of discussion on race and ethnicity. What about economics as a social determinant of health? For example, data on income or food security as an indicator of economic status is not collected with COVID testing or vaccination, but does have a material impact. Can you comment on that?
Yeah, no, it's a great question. And I think that what I would say is that there actually was a lot more focus on socioeconomic status prior to last year. And in the clinical world, because the world of public health, I would say, and sociology and others have known about the social determinants, but the clinical world, this is kind of newer in the past 6-7 years, I would say. But there was much more attention to socioeconomic status. You saw reports coming out from the National Academy of Sciences, Medicine, and Engineering, as well as the Assistant Secretary for Planning and Evaluation, looking at socioeconomic status as measured by dual status in Medicare for those individuals who are dually eligible for Medicare and Medicaid as the focus of attention. And a lot of people were looking at poverty and that focus, and not looking at race and ethnicity. And when we talk about the importance of why it's actually all of the above, but you can't use one for the other, that it really is thinking about the intersectionality of where people live. We don't just fit into one box. So I'm not just a woman, I'm not just Black, I am not just, whatever. I am a combination. And similarly, when we look at socioeconomic status, we do see that a lot of disparities disappear, but you still have racial and ethnic disparities that remain. So we need to take that holistic approach and look at all of the factors, including things like rurality. And that was one of the things we did in combination with the CDC Office of Minority Health and Health Equity, was to look at racial and ethnic disparities in rural communities. So you see that even in different places, there are those. So we need to take that intersectionality approach and look at all of these factors.
And that was going to be an area that I was going to explore, but we don't have time. But next time, Cara, we're going to talk about rural health, because that's the context in which we met a few years ago.
Yeah.
We have about 2 minutes left, and I want to make sure I ask you this question, because I think it's important, and I think it's important for all of us to hear the answer, which is, so just to set the stage a little bit, we're all inspired by different things. And yesterday when the verdict came out, of course, I was watching television like so many others. There's a young 11-year-old girl who was at the square, at George Floyd Square, and she was so articulate, and she said, this is a big moment. And I would expect that that little girl is going to be inspired by that moment for the rest of her life. Who knows how she will act on it. I'm just wondering, you have for all of your career focused on equity and now health equity. And I'm wondering if you can point to anything, anyone, a situation that inspired you to do what you do.
That's a good question. I would say it's really those collectively who came before me. My parents have always had a focus on sort of justice and making sure that we have equity in whatever we do. And so they like to say that they remember in preschool that they took us to a protest on the mall, and we went to preschool the next day, storming in, FBI, CIA, ain't no justice in the USA. So I think it really is just a embedded innate focus that is part of a long history and tradition that we have of making sure that we leave the world a little bit better for those who come after us, and that we learn from our past and see what we can do to make it better.
Well, you have certainly paid that forward and continue to make the world better for those who will come in front of us. And so we thank you for that. We really appreciate the time that you've spent today and how much you've shared. I'm hoping that in the future we can talk again. I would love to explore that concept of rural health. It's so important in the intersection of it. So thank you so very much.
Thank you.
Dr. James, Dr. Georgiou, thank you so much. And again, following our keynote, this conversation from you, I just kept nodding my head. And thank you for leaving us with that message of empowerment, and that we should not think of these problems as something we cannot solve, and that providing for so many good examples, concrete examples of how we can do it. Thank you so much again for joining us.